lot of people will be rolling in as the day goes on. But welcome. This is the David Payton Lectureship in Academic Global Ophthalmology. I'm Brad Feldman. I'll be helping to moderate the day. Just want to say a few words first about Dr. David Payton. Dr. David Payton, for those of you who don't know him, was a visionary and really legend in our field in ophthalmology. He was a graduate of the Johns Hopkins Wilmer Eye Institute and went on to form Project Orbis. Project Orbis, otherwise known as the Flying Eye Hospital, was the concept which was thought to be crazy at the time that Dr. David Payton developed it. It was that you could take an airplane and outfit it as an operating room and fly it around the world to teach eye surgery. And that's exactly what David Payton did. He raised money with the help of people like Alice Lee Tasman, who's sitting here in the audience today, and was able to make this dream a reality. And Orbis was one of the first international non-governmental organizations or nonprofits working in ophthalmology to try to address the burden of global blindness around the world. And David Payton went on, he was the chairman at Baylor. He also went on to become the first medical director of KKesh, King Khalid Eye Specialist Hospital in Riyadh, Saudi Arabia, which is a well-known eye institute, and he helped build that hospital up. And he's become a mentor to me and a patron of our program here. And he came up with the concept of what he calls academic global ophthalmology. What is academic global ophthalmology? What's the idea that instead of having a haphazard approach to trying to address the blindness around the world, it was the idea of really bringing in the universities around the world to think about a scholarly way to approach blindness prevention and elimination. And we can talk about academic global ophthalmology probably for hours, but one of the questions that we've had at Wills is how do we take this great eye hospital, Wills Eye Hospital, and really engage in a productive and efficient way in partnering around the world in global blindness prevention. And one of the main answers was to find great partners. And the best partner that we found is sitting here today. Both of them actually are here today, Dr. Ciku Mathenge and John Kirke, Dr. Ciku is our visiting professor today, who's going to be taking over in just a moment. And so Dr. Ciku and Dr. John both come from Rwanda today. I think they took a little course through Los Angeles where they got stuck in the airport for a while. But they come here from Rwanda, where they lead the Rwandan International Institute of Ophthalmology, which they founded in 2011. Dr. Ciku was the first ophthalmologist in the region to become not just an ophthalmologist, but achieve a PhD, which she got at the London School of Hygiene and Tropical Medicine. She has a strong history of research. She was the first. She performed the first RAAB, which is Rapid Assessment of Avoidable Blindness, and helped work on that methodology, and also performed the first RAAB, which is a way to evaluate the prevalence of blindness in a region in Rwanda. She did a national survey of Rwanda with some help from our team, actually, but led by Dr. Ciku several years back. She and John are really the leaders of ophthalmology for the country. And what we're really excited about is about a year ago, they were able to get off the ground an ophthalmology residency program, the first training program in ophthalmology in the region, and really a huge milestone for Rwanda, a country where every ophthalmologist has been trained outside that country with various different training qualities of the training programs. And so now Dr. Ciku and Dr. John are trying to create a residency program that's high quality, high standards, so they can produce the future of ophthalmology in their country and guarantee that's going to be high quality. So Dr. Ciku is going to talk to us and give us a couple lectures here over the first 2 hours of the afternoon. And then for the second half of the afternoon, we're going to have our residents and our global fellow present on their international experiences over this past year. So Dr. Ciku will take over now from 2 until about 4. And then at 4 o'clock, our residents, who are our senior residents who participated in the WIRE program, or the Wills International Residency Experience, will talk about where they went and what they learned in their 1 to 2 weeks abroad. And then we have one of our global fellows. So part of our Wills Eye Center for Academic Global Ophthalmology is that we run a fellowship, which allows some lucky ophthalmology graduate from the U.S. to spend half their year working with our partners abroad and half the year teaching here at Wills and learning. And so we have 2 fellows this year. One of them is actually in Sarabu in Sierra Leone right now, I'm getting ready to do 2 weeks of surgery with our partner Kathy Shanzer there and our former fellow Christos Ifantidis. So Suzette Luke is there, but we're lucky to have Zubair Ansari, who's here, who will talk about his experience this year. So without further ado, I don't want to take too much of Dr. Ciku's time because she's an incredible speaker, not to create super high expectations, but you really should, because she's one of the most dynamic and powerful speakers I've ever heard. She's brilliant. She's really a force to ophthalmology. She's going to do a world of good, and she already has, in Rwanda, around the world. And we're so lucky to have her here, to host her, and to be fortunate enough to be her partner in this venture in Rwanda with the new residency. So, Dr. Ciku, thank you.
Thank you, Brad, for that introduction, and thank you to everyone who is here this afternoon, and also for those who are watching the webinar. Some people have asked me how I met Brad. It was not a match made in heaven as such. Brad came to Rwanda after being introduced to a partner in Rwanda by somebody, and it's kind of a story of a young man who went to chase this suitor who was not very responsive. He tried to woo her with some goodies, kept adding viscoelastic here, I'll add some foldable IOLs, but the partner was not budging. And Brad just kept planning his trip, buying his tickets, getting ready. And then at the last minute, the suitor sort of said, you need an invitation letter, and I'm not ready to do it. And then somebody said, well, why don't you try this other person who might help you? And he came to us and found that we were more needy and more embracing, sort of like a desperate woman. And that's how the relationship started. And so our loss was our gain. And it has really been, after that, a really productive match. So this afternoon, I have two presentations. One is really just the story of who we are and where Wills has been working with us and what that partnership looks like. And the second part of my presentation will be about what I see as changes and trends that are happening in eye care in Africa that will probably impact on the way that those who want to interact with Africa, they should be aware of those type of trends. So I come from Rwanda. Rwanda is almost invisible in Africa. It's a really tiny country right in the center of Africa. It's not that tiny when you're there. It's a very hilly country, and my son says that actually Rwanda is quite big. If you could only iron it out, it would be bigger than Tanzania. Every piece of the terrain is a hill, so it's a beautiful country. I couldn't find a picture of our president with your current president, but I found one with the previous president. Rwanda is a land of very tall people. That's the president and his daughter, not his wife. Yeah. So I will talk about three things. One is the workforce gap that we have in Africa. Secondly, the path that we in Rwanda follow to try and fill in those gaps. And finally, how RIIO and Wills are working together to fill that gap. I'm sure most of you know that there is a universal problem of shortage of health workers, and this problem is most acute in Africa, as those numbers tell. It's more acute in eye care, as Africa has only 1% of the total number of ophthalmologists, despite having a big burden of the blindness that is there in the world. If you look at the number of ophthalmologists per million, this is data from IAPB. This is from the IAPB Vision Atlas, which is a great resource, and those of you who haven't visited this atlas, it's really a great resource for you to find out numbers that impact blindness. As you can see, Africa is really very, very poor in terms of numbers of ophthalmologists to serve the population. Not only are the numbers few, but the distribution is very skewed. Most of the ophthalmologists are in large towns, and huge parts of countries have absolutely no ophthalmologists. So let me go to the story of Rwanda. Most people know Rwanda because of the genocide. And as Brad said, we stopped in LA mainly to take our children on holiday. And as we were having tea one day, a gentleman came up to us and said, "Where do you come from?" And he said, "From Rwanda." And he said, "Oh my goodness, how do you feel? You must be feeling it's just good to be alive. Thank God I escaped the genocide." So I think that is what people know about Rwanda. So 1994, we had the genocide, a lot of people dead. And this had a huge impact on the health system. A lot of the dead people were the health workers. There were no health services. Life expectancy was very low. HIV and malaria were rampant, malnutrition. There's no water system, no bank system, no education system. So this is sort of the country that was there immediately after the genocide, which is when my husband, John, returned to the country. And so the shortage of health workers was acute, yet the need was very great. So how do you then deliver eye care in that environment? Actually, you don't. First, you have to put your house in order, which is exactly what happened. The government put in all its resources into just installing water and sanitation systems, trying to deal with infant mortality, managing the killer diseases, started training basic health cadres, put in systems for health financing, just the basics. There was no thought about eye care at that time. And during that period, John was in training. 2002, Vision 2020 is the thing to do, and the first national eye care plan is written in Rwanda. Actually, Rwanda was one of the first countries in the East Africa region to have a plan. And the plan was, as in any other plan, aiming to put the right number of eye workers in the right place, give them the right tools, and provide the right services. However, after the plan was written and approved, it was realized that there's actually nobody to run with the plan. And so back to the drawing board and thinking around which services could be delivered where and what was the most prudent place to start. And like in any country, you can divide the health services into the primary, secondary, and tertiary. And after much discussion in terms of what could be done at what level, the decision made was to invest first at the secondary level. And so a cadre called the ophthalmic technician was created. This ophthalmic technician is not like the ones you have here. They are clinicians. They are employed by government, and they can diagnose, they can treat, they can refract, they can refer difficult cases, and they can host surgeons who can go to their hospitals for surgery. And we decided that this was the most appropriate cadre to invest first in. And as you can see in the pictures, they can do a lot of things. This guy is doing some biometry. The other one is the assistant, the scrub for the surgeon. And they also run all the district hospital eye clinics in Rwanda. After that step, the next step was to look at the primary level. And in Rwanda, we have a primary eye care curriculum that basically teaches nurses in health centers how to do a basic eye exam with the aim of differentiating a normal eye from an abnormal eye. We did not want to, make it complicated, but just they should treat basic things and refer everything else, but they should know where to refer, they should know what message to give the patient. And this is available within 5 kilometers of every household in Rwanda. It means every Rwandan can walk to the nearest health center and get a basic eye examination. So after those two levels were tackled, this is what happened. This is our health information report of 2008. And as you can see, there is no eye condition among the top 10 morbidities that are reported across the country. And this was a bit surprising for us because we knew that there are many eye patients in the country. But after we had a few people in place, after the first batch of ophthalmic technicians were trained, at this point we hadn't even trained nurses, this is what happened. By 2011, eye diseases suddenly start appearing in the morbidity data. And this was important to us because as far as governments are concerned, if you don't exist as a morbidity, then there's no planning for you and no resources can come to you. But once you are in the top 10 morbidities, then you have a right to demand some resources. So already just by putting people in place to manage patients and collect the data, eye diseases started featuring in the morbidity reports of Rwanda. And even in health centers, by the time the nurses were posted there, within a short time, eye conditions also started appearing in their statistics. And this has been sustained. The most recent data I could get was 2016, and this is across all health facilities in Rwanda, and you can see that both for the under 5s and over 5s, eye diseases are in the top 10. This has allowed us to mobilize resources and also sensitize the government about the importance of eye care. And we are seeing a real change in the attitude of government with real resourcing coming from the Ministry of Health for eye care. So where do WHEELS and RIIO come in all this? We've done 2 RAABs in Rwanda, one in 2007 and one in 2015. Both of them showed the same thing. Cataract is the leading cause of blindness in Rwanda. And as you know, cataracts need ophthalmologists. Many of these other conditions probably can be handled by other cadres, but cataract needs ophthalmologists. We did have ophthalmologists in Rwanda, but we thought more investment was needed at that level. We had at this time sorted out the health center level, the district level, and it was time to now think about the tertiary level. So RIIO is an organization that was started by John and I, and we registered it as a local not-for-profit in 2012. We had various goals. We wanted to start some community services to help meet some of the needs that were there in terms of surveys. We wanted to start a school of ophthalmology. We wanted to engage in research. In fact, RIIO was involved in the 2 RAABs that were done. And we also wanted to have a state-of-the-art clinical facility. We ended up partnering with a private Indian outfit for the clinical services just because we realized running a hospital was much harder than we anticipated. And we have had a very fruitful partnership with Dr. Agarwal's Eye Hospital. That is a completely private entity now. In the community services, we not only tackle cataract, but that picture there is of children who've benefited from free corneas. John runs a very robust cornea transplant service, especially for children with keratoconus who have dropped out of school, something that is very, very common in Rwanda. In terms of the school, why did we want to start the school? By 2018, we had 16 ophthalmologists in Rwanda. All these 16 ophthalmologists are trained outside the country, and as Brad said, they come back with various levels of skill. 5 of them do not perform any surgery at all, and 4 of them are undergoing retraining in cataract surgery despite the fact that they had finished residency elsewhere. 6 doctors who have in the past 5 years received scholarships to go out and train as ophthalmologists chose either not to return to Rwanda or abandoned ophthalmology. This despite government having found scholarships for them to go and train. And the government was becoming concerned that training people outside is quite a wasteful way of doing things. As RIIO founders, we are convinced that we could produce better ophthalmologists by training them appropriately for our needs, but also that we could increase the number of ophthalmologists in the countries more rapidly if we had a program locally. We also saw the residents as a resource in that while they were training, they would be serving Rwandans rather than serving Kenyans or Tanzanians or wherever it is they go for training. So our target was to enroll 4 doctors each year. And if we do that each year, we will have doubled the number of ophthalmologists by the year 2026 and still have 12 more in training. During the course of training, the residents will perform 1,000 extra cataract operations, and this is not a lot, but it would represent a 20% increase in the number of surgeries done in the country. And research in eye care will improve because all these residents are expected to do some research. So these are some of the targets that we thought a local training program could achieve. As you can see, we've only had 4 residents for 1 year, but they are already out there in the community doing surgery. You can see a Wheels fellow there, Zubair, who came and spent 2 stints with us. They've been involved in research already, and we are pretty happy with how the program is going so far. So of course, we had a lot of challenges. We've never done this before, and we are not experts at training. So how is Wheels helping us? Our number 1 challenge was faculty. Number 2 challenge was faculty. Our number 3 challenge was just having a program director or the support that goes with running a department. A lot of this rests on my head or on John's head, and many days I go home feeling like this woman. Maybe Wheels is the bicycle that I ride on. I don't know. I don't think it's the pot on my head, but yeah, it is a lot. We have to run a hospital. We have to do the training. We have to run the program, and it's quite a lot. Because we have only 16 ophthalmologists, it's also unfair to expect them to have enough time to, again, dedicate to a new program. So this has been a big barrier for us in moving forward. Another barrier has been a suitable training clinic. We do have a fancy hospital, the Dr. Agarwal's Eye Hospital in Kigali, but those are private patients who are not always very happy to be seen by residents. And another challenge has been credibility, because we are training people outside a university system. This is very unusual in Africa. I think we are the only program like that. Most residency programs are attached to universities. At the time we started this program, John was the head of the medical board of the university in charge of medical education, and I was head of department of ophthalmology, training the mid-level cadre. We were both certain that we did not want to run this program out of a university, mainly to get out of the bureaucracy and the restrictions that a university MEd program puts on you. But it also meant that then we had to convince people that what we were doing was credible, it could be accredited, our graduates could be certified, and we've overcome all those barriers, but certainly having the support of an institution like Wheels does help us with that credibility. This is the list of visiting faculty that we had 2018-2019, and as you can see, Wheels has been a big contributor. And this has unlocked one of the biggest barriers that you have. The Wheels faculty has been there to help our trainees in basic sciences, in clinical skills, in the wet lab, on outreach, everywhere. Wheels faculty helped us even as we were designing the curriculum, the assessment tools, and we are really grateful for the big help that has been and the barrier that it has helped to break. As you can see, we also have a good number of local people who are willing to participate in the program but are restricted by the amount of time that they can spare. Wheels has also supported us with books. We were lucky that Brad had some link with RAAO at the time that he joined us, and we really made use of that link. We have more basic science books than residents, and each one of them could have a full set. That really made a difference for them. And also access to the webinars here, access to other sites that they could use for their learning, that has been really useful. We are now about to start a residence clinic. The government has allowed us to adopt an eye clinic in a district hospital and run it as a residence clinic. Actually, they like the model so much that they're offering us more hospitals than we can adopt. And we have managed to equip the equipment thanks to the generosity of an organization called Himalayan Cataract Project. But again, we cannot run a clinic with residents only. You need attendings to work with the residents. And this is a new opportunity where WILS visiting faculty will be extremely useful for us, because it will be difficult for John and I to go to the residents' clinic as well as remain at our base hospital. So how are our residents doing? This is hot off the press. So we didn't set any local exam. We believed that our residents should be able to match up to international standards. I did not want the work of setting a local exam. And I said, you're all going to sit ICU exams, and you're going to sit both Part 1 and optics and refraction at the same time. And a lot of my colleagues said, this is difficult, you're putting a big barrier for your residents, it's the first time you're doing it. They all passed. I was really very proud of them. Not only did they all pass, but as you can see, if you look at the average for the world and how Rwanda performed, they are all above the world average. This is in the visual sciences, this is in optics and refraction. My students haven't even seen these results. So it means that with the right support, with the right attitude, with the right resources, this is possible, even in a country like Rwanda. And I'd really like to thank all the residents and the fellows who visited and worked with my residents, because that has contributed to this result. Do you guys know this picture, these people in this picture? John and I. You know the other two? Does that help? Okay. So one of the linkages that we had was that Mr. Lurie, the owner of Philadelphia Eagles, came to visit Rwanda, introduced to us by our collaboration with WILS. He wanted to support pediatric eye care in Rwanda based on a model that he runs with WILS. And as a result, we just completed one of the largest school screening projects done in Africa, where we have screened 19,260 children. And we are just about to publish this. The results were a bit surprising for many people. In fact, we were happy that Dr. Levine could come on the ground, because had I just sent him the results on a piece of paper, he'd probably not have believed them. But basically, we had a very little refractive error, and a lot of the children that came out of this project need surgery. Majority need strabismus surgery, and the other half need ptosis surgery. And this is usually something that when you do a school screening project, you don't plan for. Most school screening projects plan for giving out glasses. Only 0.1% of our school children needed glasses. There's been benefits for WILS, of course. We always wanted from the beginning that this relationship is mutually beneficial. I think the success of WILS and its partnership with RIIO will increase your visibility as a player in global ophthalmology, especially in our region. The only thing we knew about WILS was the book, which is sometimes the only textbook we have as residents. Now we know there is a face to WILS. There are big opportunities for research. As Brad said, when we did the RAAB, I had a WILS fellow who joined the teams. It allowed me to have an extra team to go to the field and do the RAAB quicker. We are talking about DR screening, that we want to initiate the first program in Rwanda, and of course I've talked about the school screening. There are opportunities for new training settings. Every resident clinic that we will adopt is a potential site for WILS fellows to come to. And when we go on outreach as RIIO, WILS fellows are always welcome to come. Those are great opportunities to learn small incision cataract surgery. And one of the exciting things that happened is after Brad and I had a relationship eventually, now more people are willing to support that relationship. We are extremely grateful to See International that has put in resources in trying to make sure that this relationship is strengthened and has more substance. And this is through the LINKS program that runs out of the International Center for Eye Health. And this collaboration with C and LINKS will allow us to do more things and do things faster and better. So Rwanda has changed a lot since 1994, and there's been a lot of success in a lot of things. Life expectancy has risen. It's actually now 64, not 56. This is quite an old graphic. Almost everybody has access to HIV therapy if they need it. It was the first country to say that everyone with HIV should have access to free medication. We have a national insurance cover that works. 90.6% of the population are enrolled. And we've tackled the infant mortality, we've tackled malaria, and I think using this same momentum, we are going to also have very good results in eye care. We do not have trachoma in Rwanda. It's the only East African country without trachoma. Do not have onchocerciasis. Our ophthalmic technicians are going through JACAPO certification. We already have 15 of them who are certified. We have adjusted the essential drug list so that now it includes things like Avastin. We have a national reporting system that includes eyes and collects quite deep, detailed data on eye care. Cataract surgery is covered by community insurance, so we do not have to come and pay for people's cataract surgery. We should allow them to use the community insurance. And we'll soon, I believe, produce the best locally trained ophthalmologists in our region who will be ICO certified. We are sure now that our knowledge training has been good. That was the easy part. I think skills training will be more difficult, but I see that your motto as WheEls is skills with compassion, and that compassion will make sure that our residents also get the skills that they need using the resources that we can partner with you for. Thank you.
Does anyone have any questions for you? I want to just say that I'm So first of all, I just want to say, you made it all look quite easy, what you've done, but what they've been able to do in Rwanda, even though it's a very progressive country that's been stable, it's hard to, really hard to get a program like this off the ground. And Dr. John and Dr. Ciku have been really advocating for a long time to get this residency started. And it wasn't easy to do. There were a lot of hoops to jump through, a lot of politics to work through to get this going, especially, like you said, as a private hospital that wasn't part of the university. So to see them come this far in a relatively quick time, and there was a time last year when I spoke to you, I think in January or December, and you said, well, the residency might happen at some point, in a few years down the road. And then I think we talked in February, and you said, oh, the residents are here. It suddenly happened like that. And then see you go from that to the point that you have all 4 of your residents passing with flying colors on a very difficult exam. The ICO exam is actually very, very hard to pass. It's, hats off to you and what you've been able to do. That's not an easy thing to do. So I just want to give you a round of applause for that. We have time for questions. We did have a question online too that I can ask in a moment as well. But Liz, yes, stand back up.
Thank you, Dr. Ciku. That was really interesting. My name is Liz Krebs. I'm an emergency physician here, and I've done some work in Rwanda and have heard a lot about you and your husband and RIIO and all of the work here, and have been excited to meet you guys. I'm curious, when your residents finish this program, how do they fit in to the larger health system and university scheme and all of that with you guys going outside the university?
Yeah. So, as I said, that was an area of concern for us at the beginning. It was a model that was quite new and difficult for people to understand. Our biggest supporter now is actually the Ministry of Health in Rwanda. Our 4 residents are employed by the Ministry of Health, so they are in service for the government of Rwanda. and are bonded to work for government in government hospitals for 3 years after they graduate. In terms of certification, they are certified by the College of Ophthalmology of East, Central, and Southern Africa, which offers a certification that is valid in 12 African countries. It's the certification that people who train in universities are aiming for even after those programs. So because they are already Ministry of Health employees, I don't expect any, in fact, the ministry wants them out as soon as possible so that they can start providing services. We have just recruited the next batch, and again, the ministry is saying, tell us who they are, we will employ all of them.
That's fantastic. And do you have any assurance from the Ministry of Health that in the centers where they'll go to work, they'll have the infrastructure that they need in order to perform at the top of their training?
So we've put in a lot of effort in eye care in Rwanda in the past few years. Actually, most district hospitals have equipment that has no one to use. We also have provincial and referral hospitals that are fully equipped to run with eye services. What is lacking is the people. So, and this is one of the reasons why the government is so keen to have these doctors graduate. So there are already stations that are ready for them, and we hope that as they train, we will sort of help them start identifying with their future postings so that they start being known by the hospital where they'll work. And if they need more resources, we have 3 more years to start looking for that.
Thank you. Congratulations, and I hope that you guys will work with so many other areas of the Ministry of Health and the university to teach our other sections how to achieve what you've achieved, because it's a burden for a lot of different specialties that are being trained now. But yeah, congratulations.
Thank you.
So, Dr. Ciku, so you had mentioned that, one of the main reasons for creating this ophthalmology program, one of the main motivations was cataract and cataract surgery and the need for it and the need for an ophthalmologist to take care of that. Now that you've created the program and we have places where the ophthalmologists can go, what about the supply chain issues of getting intraocular lenses for patients who need cataract surgery? Is that something that the national insurance will be covering, or is there a plan in place in order to get those intraocular lenses?
So in terms of the supplies that you need for basic small incision cataract surgery, the national insurance covers all that, including the cost of the intraocular lens. What is a challenge is the procurement process for those to be available in district hospitals. At the moment, that is not really well done, and thankfully we have a lot of not-for-profits that work in the country and sort of create stockpiles of these consumables. So when we go to, like where Dr. Ansari was photographed, when he goes there, we are basically providing the human resource, and the not-for-profits will provide the consumables, and the hospital will provide the patients and the space for us to work. So it's that sort of collaboration. We think that as these doctors, as ophthalmology becomes more prominent within government hospitals, then the central procurement department will have to develop better services for stocking up on eye consumables. But at the moment, because the services were not there, it was also hard to lobby for them to stockpile consumables that have no users.
Thank you. And I can keep asking questions. I know that you're working with several other nonprofits. Orbis is now in the country. You've worked with Fred Hollows in the past. You mentioned Himalayan Cataract Project. Beyond the stockpiling of consumables, what are your relationships with the residency and these nonprofits and the government? How have they been working together?
So our goal as RIIO is that everybody matters, and whoever can support us, we want to work with them. And the not-for-profit have been our big supporters. So Fred Hollows Foundation, for example, pays the tuition fees that allows us to run this program for these 4 residents. And this coming year, we have another not-for-profit. CBM is going to pay for 2 of them. And Fred Hollows, for example, also helped us set up our wet lab at the institution. So we've just been basically soliciting for whatever help we can from anybody, and we have found, the organizations are incredibly supportive and receptive, and they understand what we are trying to do, and we are really grateful for that.
Hey, Dr. Ciku. So first of all, congratulations on the residents passing the ICO exam. To you and Dr. John, I think that was a remarkable achievement and a testament to our collaboration with Wills. The question that I have is, if I'm a community ophthalmologist in the United States and I want to get interested in helping out the residency program,
Yes.
What do you feel is my role, and how do you think that I could most benefit to a trip to Rwanda?
Okay. So, as I said, everybody is welcome, and I believe that everybody can contribute. What I always tell people who want to visit is come and do what is comfortable for you. So, for example, if you feel you're a phaco surgeon, you've never done small incision, then come and teach my residents phaco. So don't go outside your comfort zone, because then the experience is not comfortable for you. But I believe that whichever area you're in, whatever you're doing where you are today, there's something that I can learn or my residents can learn from you. And if you write to me and say, I want to come, usually the conversation is, what do you want to come and do? And some people say, I want to come to the OR. Others say, I want to work in the clinic. Others say, I want to teach. And we work out a plan that is suitable for you with the skills that you have that will make you feel that you're contributing the most. For me, I am like a sponge. I can absorb everything, and I'll throw in a few gorilla trips in there for you to make your week enjoyable. But whether you are, this is in my next talk too, whether you work in medical records, we could do help with medical records. Whether you work in research, you can come and collect data for us. There is always somewhere where we can do with help. So it doesn't matter whether you're a community ophthalmologist, it doesn't matter whether it's the man who's recording this talk, there is always something that you can help us do better. Yeah.
That's a shout out to you, Bill and Jack. So I think we can take a break for a few minutes so we can walk around, stretch, and we'll reconvene again in about 5-10 minutes, and you can start with the next talk. Thank you so much, Dr. Ciku.
Thank you.